So we shall go on to our next speaker. Our next speaker is Dr. PARTHAPRATIM DUTTA, who's a senior consultant, Department of Uvea and Intraocular Inflammation, Shankar Nethralaya, Chennai, and he is going to talk on lens-induced lens and IOL associated uveitis. On to you, doctor.
Yeah, good evening, everyone. Thanks to Dr. Chitra Ramamurthy and team ARC of AIOS for having me here. The topic of my presentation is lens and IOL associated uveitis. I'll show 2-3 very interesting cases and try to share some of the pearls I have learned from them. Many believes that there is an immune privilege to the crystalline lens as it is isolated from the fetal circulation early in the embryonic life, lacks innervation and avascular. Outside the lens capsule, the lens protein behaves as an autoantigen and can cause inflammation in the anterior chamber or inside the eye. This property of antigenicity increases.
Excuse me, all of you, please stay muted. Yes.
Yeah, so this property of antigenicity actually increases in mature and hypermature cataract and is attributed to the conversion of the soluble crystalline protein into the insoluble protein. So basically, lens-induced uveitis is an immune reaction to the lens protein and can be broadly divided into 3 forms. The number 1, when there is a rupture of lens capsule, like in trauma or iatrogenic cases. Second, when the lens capsule is intact, but there is leakage of the protein, lens protein into the anterior chamber. The third, when there is a retained lens material following any procedure or cataract surgery most commonly. So this is the photograph. I have collected it from Dr. J. Biswas. So this is here you can see the macrophages engulfed here. It's showing the macrophages engulfing the lens material in anterior chamber aspirate. So classically, the phenotype is it causes any lens fragment or lens protein causes a zonal granulomatous response. So now this can be in practical scenario, it can be a granulomatous uveitis presenting with posterior synechia and capice, or it can be a non-granulomatous anterior uveitis presenting as a painful eye with no keratic precipitate. And as we showed here that macrophages, the lens engulfed macrophages can also clog the trabecular meshwork and cause raised IOP. So this kind of lens associated uveitis often can cause pseudohypopyon, as you can see in this picture, or sometimes these deposits over the corneal endothelium can mimic the mutton fat keratic precipitates. So one has to be very careful while evaluating these cases. Now coming to the retained lens fragment, these are highly immunogenic, but it can't, the rate of antigenicity can be variable. It can take 2 weeks to 1 year time to show the antigenic response. And it can be actually sometimes missed in patients with dense arca senilis. As you can see here, there is the cause of uveitis was a small lens fragment which was sitting here. So this kind of actually the lens fragment most commonly seen after uveitic cataract or after complicated cataract surgery, especially when we use the Grischerber hooks. Sometimes the left or remnant of the pieces can be there inside that tent-like configuration of the iris, and it can be rarely can occur in cataract surgery in small pupil also. So gonioscopy is a very useful tool. And sometimes in suspected cases, UVM can help. Here is another patient, an 18-year-old female, recurrent attacks of redness and eye pain in the left eye, presented with a diagnosis of granulomatous uveitis for 6 months. And there was extensive oral steroid use, as you can see from her skin lesions here. So this is the slit lamp photograph of the patient. As you can see here, the minimal cells, annular synechia, and her IOP was 28 millimeter of mercury. She gave us the history of phacoemulsification with foldable IOL implantation 7 months back. She denied any symptoms of redness, irritation prior to that. and all her laboratory workup done elsewhere was normal, except for the normal serum angiotensin converting enzyme. When we did a ultrasound biomicroscopy, you can see here it showed us the IOL in the sulcus. And we, from her medical documents, we could make out that there was a single piece IOL placed in the sulcus. So this was the cause of her recurrent inflammation. This is the picture after the removal of the IOL. Her FAK correction was 6/9, base corrected visual acuity was 6/9, and IOP came down to normal. So what happens there occurs a mechanical iritis, which results into the chronic inflammation following the surgery. So single piece acrylic IOL should not be placed in the sulcus. Here is another case, a 62-year-old female presenting with a chronic anterior uveitis in left eye, denies any history of redness, irritation. And as you can see here, she was treated with topical steroid, oral steroid, extensive laboratory workup was done, and the PCR from the aqueous aspirate also was done, which was negative for all viral genomes. So the slit lamp examination showed mild chronic inflammation. Fundus examination was within normal limit. I'm sorry for this poor quality of UBM picture, but you can see here it showed the IOL in the haptic was inside the bag, but when in undilated condition, it was showing that the IOL optic was rubbing the iris. Just this, like this graphical representation, it was rubbing the iris here. So mechanical rubbing by the edges of the optic can rarely causes this kind of uveitis, chronic uveitis, and it happens when, while doing cataract surgery, we make a large or eccentric capsular rhexis. Also with patient with zonular laxity, when there is a plateau iris configuration and the lens pops up, IOL pops up little bit. So it has to be very careful while placing your IOL. As this is another patient, you can see the IOL optic is just above the coming out from the bag and was causing extensive and chronic inflammation. This is another lady, 59-year-old lady, following the phacoemulsification and trabeculectomy. The vision was 6/24. And she was complaining of diminution of vision. We could make out the cellular deposits like material all over the intraocular lens. We tried to remove it, thinking it as a inflammatory membrane with YAG. It was not possible. Surgical intervention with scrapping also, it failed to remove this membrane. So finally, we explanted this IOL, and the hematoxylin histopathology showed actually the numerous histiocytic cells, and it was showing the chronic granulomatous inflammation. So you can see here the multi.
So 1 minute remaining.
Yes, I'll be finishing soon. So this is another case. Similarly, the patient presented with the ossified IOL, and you can see here, we did here this time after removing the IOL, we did a electron microscopic photograph, and as you can see here, you can see this inflammatory cells. There is a cellular invasion into the IOL surface, and here you can see that it was going inside the IOL material. So sometimes this kind of can occur with, especially with the silicon plate IOL. So just to conclude my talk, the lens and IOL associated uveitis, the history is very important. The patient will tell you that he or she never had this kind of redness or irritation prior to the surgery or prior to this episode. High index of suspicion is required, and you need to rule out the other etiologies, other causes of uveitis in such scenario. And presence of abnormal amount of pigment dispersion over the IOL should give us a clue about this IOL associated uveitis. And the gonioscopy and UBM can be very helpful and can help us in difficult or challenging cases. Thank you.
Thank you very much, Dr. Partha. A question here is, we know that if there's an injury in the eye, and it could, uveitis could present in days or years also. The patient doesn't give you history. Now in these IOL settings, it's very probably not too difficult to locate the IOL as the cause of the inflammation and go ahead and get more aggressive on that. But in those other cases, lens-induced uveitis is a clinical diagnosis. So how would you investigate? I'm not clear, I think, as a question.
Yeah,
What
I think you wanted to mean that how to differentiate a lens
Yes.
in this uveitis from
From
other
other
causes of
forms.
uveitis.
Yes.
Yeah,
Yes.
so as I said that the clinical phenotype can be it can be a granulomatous uveitis. So you have to rule out the other granulomatous uveitis. But as I said, the history is very important because the patient will give you a history that he or she never had any history of redness irritation prior to this kind of episode. And second is that the lens matter, you can actually, if you look carefully, you can differentiate from the differentiate these cases clinically, because these usually will present with hypermature or mature cataract.
Yes.
And sometimes if you have hypopyon, you can do histopathology. The lens matter will be engulfed by macrophages in lens-induced uveitis. Sometimes.
Yeah, I was looking forward to that answer. Yes.
I just want to make one comment.
Yes, Doctor.
Yeah, can I make a comment?
Yes, Dr. Vishwas.
So, actually, when you are doing that experimental animal model of uveitis, lens-induced uveitis is one of the classic example. When you rupture the lens capsule and break the cortical material in animal model in rabbit or rat, within 7 days there will be granulomatous inflammation involving the whole uveal tract, and that you can use it for various experiments. So lens-induced uveitis is a very common uveitic entity, and if we rupture the lens capsule, there's a very high chance of development of lens capsule until unless you remove all the cortical material.
Dr. Virendra Sangwan, do you have anything to add here? It's not connected.
Dr. Chaitra, can I add
Yes.
Yes, Dr. Vishal.
something?
Yes. Yes.
Hello.
Yes, we can hear you. Tell us. Dr. Vishali?
Yeah, Dr. Chitra.
Yeah. Yes, doctor. Can you add your thoughts to this?
Yeah, the retained cortical matter or a piece of cortex remaining in the anterior chamber or a traumatic cataract. It's not that every eye develops lens-induced uveitis. So one should not really rush until you see signs of active inflammation. And a large majority of patients don't develop, in my experience, that when you do surgery and small chink is remaining. So generally it does not cause, or it does also not require that you have to increase topical steroids, systemic steroids.
Dr. Chaitra, can I add
Yes,
just one point?
Yeah.
Many times these patients who have undergone complicated surgery and have residual lens matter might have associated other thing going on, like early endophthalmitis. So I think, as Dr. Biswas and Dr. Ratinam pointed out, doing a tap and looking for macrophages and all would be very helpful in these situations.
Yes. Very true. Dr. Avinash, you have anything to add before we go on to our next speaker?
I just have a question to Partho, actually. So a very practical question which most of us face. Now we send our patients for cataract surgery, Partho, and if the patient has had uveitis, had to undergo cataract for uveitic associated cataract. So the patient comes back, is on treatment, and uveitis associated cataract itself sometimes can have capsulophimosis and can have some displacement of the intraocular lens. Now there would be a situation where one has to differentiate, is this inflammation is IOL induced or it is because of anterior uveitis or intermediate uveitis, any of those uveitis that the patient had prior to surgery. How does one differentiate? Because both the treatments are very different. One would require explantation of the intraocular lenses, another would continue immunosuppression. Are there any clues for us to help us identify this and take us into our practice?
I think the most important point after cataract surgery in such scenarios, as Dr. Vishali Gupta pointed out, that most important is to rule out the endophthalmitis. So this is number one. Second is the most important factor here is how good is the immunosuppression. How for what duration the eye is quiet. This is very important. And second, if the lens is placed properly, a proper capsular excision was performed, I don't think that this should cause IOL-induced inflammation in such scenario. So we have to treat it as the recurrence of the previous inflammation.
Yeah, Partho, Avinash, just a minute. See, if there is this is IOL-induced inflammation, the inflammation will be centered around the IOL, meaning you'll see extensive deposits or a membrane on the IOL, versus say if it is a uveitis recurrence or a continuation of that uveitis. You will find some deposits in a recurrence of the uveitis also, but if it is due to the IOL or its material, which is very unlikely these days because of the quality of the lens material and manufacturing quality, so the distinction usually is not that difficult.
But sir, sometimes it is very difficult that post-operative, even if it is an IOL-associated uveitis or uveitis due to secondary cause, as Dr. Avinash asked, it is very difficult to differentiate until and unless there is a severe posterior segment inflammation.
Yeah, see those severe inflammations, and that the question to IOL explantation will come once you have controlled the inflammation, once you have ruled out and endogenous and off.
I fully agree.
So those things once you ruled out.
I think the uveitis-induced inflammation is in the immediate post-op period, and IOL causes it much later. I would take timing into consideration.
Considering the IOL invasion.
Yes.
Absolutely.
Yes. Absolutely.
I was doing the pathology. Once that early period of my pathology, we used to see the lot of IOLs coming to histopathology staining, and I could see the granulomatous reaction around the haptic of these lenses. Now the lens designs has so improved and the technique has improved. I hardly see any removed IOL histopathology.
So just one line. I think the IOL-associated uveitis is a diagnosis of exclusion. You have to exclude all other causes, then only you can think of IOL-associated uveitis.
Yes. Thank you, Dr. Partha.
Can I add a few points, madam?
No, who's that? Oh, Dr. Sudha. Very brief. We have a whole lot of speakers ahead. Thanks for joining in. Tell us.
Yeah, so one thing is phacoantigenic uveitis requires a period of sensitization. So most often it's the reaction that you see in the eye is often for the second eye, not for the first eye, because there is a period of sensitization to the lens protein. The second thing is if the IOL is well cocooned in the bag, it's most probably not due to the IOL material. In those days, we used to have heparin surface modified lenses, which used to prevent these kinds of inflammation. But now the quality of lenses are much better, so we don't see that much often. Another common feature that you see in IOL-induced uveitis is a foreign body reaction on the IOL. You see a lot of IOL deposits. So that gives you a clue that it is due to the IOL. Third thing is if it is due to an infection, you see the PC plaques when you suspect a P. acne end off. So these are some of the clues to differentiate which Dr. Avinash asked. Thank you.
Yes. Thank you very much.